Hi, I'm Dr. Ken Lipstock, and welcome to our cataract surgery PowerPoint video. If you have a cataract and the possibility of cataract surgery exists, I think that you will find this PowerPoint very helpful to understand the basics as well as the details of cataract surgery. You'll get to understand what a cataract is, and when is the time to have cataract surgery, when is it reasonable to do cataract surgery, as well as what is cataract surgery all about, what's the technology, how is it done. You'll learn that there is a wide variety of techniques and technologies that vary from surgeon to surgeon. So you owe it to yourself to get educated so that you can make the best choice for yourself. In this introductory section, we're going to give you the foundation so that you could better understand the more detailed discussions later on in other sections of the PowerPoint. Here we will talk about the cataracts and the general technique that most surgeons will use today, even though there are great differences when you get into the details of how they use that general kind of technique. So to get started, let's first talk about the eye anatomy. The front window of the eye is called the cornea, and that bends light rays, which enter through that and then through the pupil, which is an opening in a muscle, the iris, inside the eye, which is the colored part of the eye. And right behind the iris sits the lens that also bends light rays. And the lens is suspended in its position with a spider web-like structure made of thousands and thousands of microscopic string-like structures that attach to the inside wall of the eye. Now, all the way in the back of the eye, you have the retina, and the space between the lens and the retina is filled with a clear gel called vitreous. The retina is a cellophane-like structure that lines the entire back wall of the eye, and it's made up of millions of nerves that funnel into a cable-like structure called the optic nerve. And the optic nerve goes back through the brain to the visual part of the brain, so the message reaches the visual part of the brain via the nerves of the retina through the optic nerve and then back to the brain. The white wall of the eye is called the sclera. So the eye is a two-lens system. The cornea and the lens both bend the light rays, so ideally they come to a sharp focal point right on the retina. A cataract is a clouding of the lens. And so when the lens gets cloudy as we age, at first there are no symptoms, but eventually images become blurred and distorted. A cataract is not a disease. Why do I say that? Because everyone by the age of 60, and most people by their mid-50s, has some discoloration to the lens, which would be a cataract. However, with early lens discoloration, there are no symptoms, and everybody gets it. And so, really, it's not a disease. It's sort of like getting gray hair. You know, everybody gets it. Early on, it starts very slightly, and it very gradually increases over the years. But the cataract does always progress. As I said, with the beginnings of a cataract, there are no symptoms, but eventually symptoms do occur. And the earliest symptom usually is glare, and halos, and starbursts at night, with difficulty driving at night, especially in the rain. Eventually, just general blurred vision, both at distance and near, occur. You may find that the glasses prescription changes, and you need to change the glasses, and that helps for a while. And some patients may notice some fading or yellowing of colors, but usually the progression of the cataract is so slow and the change in the perception of colors so gradual that it goes unnoticed until the dramatic change once the cataract is removed. So when you have a cataract, at first we just observe it, and with an early cataract we just
do a regular eye exam once a year and check that. And sometimes we'll be changing the eyeglass prescription, and eventually cataract surgery will be needed to be done. The rule of thumb for when it's a reasonable time to have cataract surgery is when the visual difficulties due to the cataract begin to interfere with activities that you like or need to do. So, for example, a truck driver with glare at night may have surgery earlier than someone who doesn't even drive at night. The glare to them would obviously interfere with their work, and it's a moot point if you're not driving, if that's the only symptom you have at night is the glare. However, you need to keep in mind that if you wait really long and let the cataract progress to where it's really advanced, then the cataract not only becomes much cloudier, but it also becomes much denser and more difficult for the surgeon to dissolve with the ultrasound device, and therefore that increases the risk of the cataract surgery. So there's no reason to do it if there are no symptoms, and usually at that stage the cataract's not going to be anywhere near being too dense to remove. But some patients, usually out of fear of the surgery, just put it off until they can't see anything, and then in that way they seem to create their own problems because they waited so long that they increased the risk of the surgery. My job is to help guide you in regards to that and sort of nudge you along if you're holding off, but the lens density is starting to look a bit suspicious, that it may cause some problems. Usually, the vast majority of times, patients ask me to remove the cataract well before it getting to that stage. Here are some simple statistics on cataract surgery. More than half of Americans over the age of 65 will undergo cataract surgery. It's half of Americans. That's a lot of people. Cataract surgery then is one of the safest but most commonly performed surgeries in the United States. More than 3 million Americans have the procedure every year. In our office, we usually do surgery on patients from their latter 50s to the latter 80s. A little unusual to do it in the early 50s, let alone in their 40s. And a few years ago, we did a study review of our charts out of curiosity just to see what was the average age we were doing cataract surgery. And in our office, it turned out to be exactly 70. Almost all surgeons in the Richmond area and elsewhere, including myself, do cataract surgery in this general way. First, your eye will be treated with some form of anesthetic prior to the surgery, so you will feel little, if any, discomfort. Then, a tiny microscopic incision is made to allow a small ultrasound instrument about the size of a pen tip to break up the cloudy lens into tiny particles and remove it from your eye. This technique is called phacoemulsification. Prior to the technique of phacoemulsification being invented, the cataract was removed entirely through a large 1-inch incision, usually on the superior part of the eye where the white heat hits the color part of the eye, and it required stitches, microscopic stitches, to close that large incision. In 1967, Charlie Kellman, a young surgeon at that time practicing in New York City, invented the technique of phacoemulsification. The story goes that he was getting his teeth worked on, and the dentist was using ultrasound to clean his teeth, and he jumped out of the chair and said, "I got it," and he then said, "I'm going to use that to try to dissolve the lens instead of removing the lens in its entirety." So that's when everything began, because with this technique, we were able to now be using a 2.5 millimeter incision compared to that 1-inch incision, which was a huge step forward in the recovery and many aspects of the procedure. At that time, with that technique, early on, there were problems as Charlie worked through the problems, and early adapters of the surgery worked through those problems. It caused, among other things, much corneal edema, patients requiring corneal transplants afterwards, and so the majority of the surgical community viewed Charlie in a very negative way, and he lost his hospital privileges at a prestigious hospital in New York City. But as with so many pioneers, it takes a certain personality to persevere. I think the surgeons who really wanted to slow him down had some very valid points. But regardless of that, it took years for this technique to be perfected to the point where by the early 90s it was becoming widely adapted. And today just about nobody uses the older techniques. It's the technology as well as the techniques has really been perfected to a beautiful, elegant procedure. Now, years later, with everything in perspective, Charlie Kellman is the father of modern-day cataract surgery and looked at as one of the most important cataract surgery or ophthalmology surgical giants in the field in the last 100 years. So when we look at Dr. Kellman's technique, you could think of the lens sitting behind the pupil as an M&M, and it's shaped like an M&M, except think of the outer coating, the green or red color of the coating as with a lens. Think of it as a bag of cellophane, and then with an M&M you have inside the coating the chocolate. Well, inside that cellophane wrapper, which is referred to as the capsule, is the lens contents. And together that forms the lens and bends the light rays. And of course, as lenses are supposed to be, the human lens is clear until you hit around your 50s, and then it starts getting that yellowish kind of discoloration very slightly at first, and then gradually increases to a more of a orange and even an amber kind of color. And also there can be white, grayish kind of discolorations in the lens as well. So to access the lens, first a cut is made in the front part of that lens and grasped, and a circular tear is performed on the front part of the lens, approximately 5.5 millimeters in diameter, to allow access to the contents of the lens. Right, so we're making a circular opening in the front capsule of the lens, and then the ultrasound device is passed through a tiny incision that's made with a microscopic scalpel, making that 2.5 millimeter incision, and that incision is usually made near where the colored part of the eye hits the white part of the eye, and so the ultrasound tip has access to the contents of the lens, and the ultrasound breaks up that contents into tiny particles which are aspirated out through that same tip. So after the lens contents is removed, the patient is left with an empty capsular bag, and this of course has no power to it, and so the vision without very thick eyeglasses would be extremely blurry, because the natural lens is a very powerful lens. So what we do nowadays is place an intraocular lens made out of plastic, and we place that inside the capsular bag. Measurements are taken preoperatively, so we know what power to use, since every eye is different in that regard. The lens is a soft plastic that we could fold into a tiny cartridge that slips through that 2.5 millimeter opening, and the lens is then placed inside the capsular bag, where it unfolds once it's inside the eye. So the history of the intraocular lens is also very important with another pioneer named Harold Ridley. It was Dr. Ridley in 1949 came up with the idea of using an intraocular lens in cataract patients because before then they were wearing those very thick eyeglasses which had much distortion to it because of how thick they were. And how he came up with the idea was during World War II when the British fighter pilots had injuries to their eyes from machine guns from other fighter planes that caused the plastic windshields to explode and enter the pilot's eyes. And Dr. Ridley, who was at a very prestigious hospital in London during the war, was operating on these soldiers. And what he noticed was that this plastic that was lodged in the eye sometimes for weeks, unlike other foreign bodies inside the eye, there was no inflammatory response. It just lied there. And he said, "Wow, that's interesting. Maybe I could use this type of plastic and use it as an intraocular lens for cataract surgery." And so then he went into the lab and started making these type of lenses using the same plastic that they used in the windshields of the World War II British fighter planes, which was called polymethyl methacrylate, abbreviated PMMA. And in fact, for decades, the intraocular lenses used that same type of plastic from the windshields of the British planes. Not literally from the windshields, but the same plastic used. And again, he was looked at as a heretic. He was kicked out of the hospital, but diligently worked on perfecting this. And again, the people who were against him had valid reasons. In the 50s and 60s, there were all kinds of problems with those lenses, again causing corneal edema. They displaced and fell out of position, but from die-hard surgeons, along with Dr. Ridley, they plowed forward for decades, and then in the 80s really started gaining steam. It took, again, decades, as I said, but finally was really perfected. And in the 90s, we started using the foldable implants for the first time, and that's when, at the same time, surgeons started adapting the phacoemulsification technique. Prior to that, the phacoemulsification technique only required that small incision, but the incision needed to be enlarged to put in the hard plastic implant. When the soft plastic foldable lenses came about, we were able to maintain that small size of the incision, and so you have the invention of Dr. Ridley and Dr. Kelman coming together in fruition boldly in the 1990s. So what should you expect soon after cataract surgery? There are a few restrictions, like no rubbing of the eye and keeping contaminants away from the eye. You can expect a mild foreign body sensation, mostly gone by the first day after the cataract surgery. And you can expect some blurriness that gradually improves over the first week. How about the risks of cataract surgery? With today's modern techniques, with a skilled surgeon, you can expect it to be at least 98% safe if there are no other problems that could increase the risk. The 2% that have some problem can usually be treated successfully, but not always. But there is backup in case there was a problem. There definitely is backup, and most of those patients end up okay. But 98% of the patients, at least, it's clear sailing. And when do the benefits outweigh the rare risks? As we had discussed earlier, the time to do that is to have cataract surgery is when the vision is blurry enough that it's interfering with the things that you want to do. Remember, the cataract doesn't stay like it is. It always progresses. And if you wait too long, it could make it more difficult to remove it. But if it's not bothering you, you leave it alone. But it's nice to know that it's extremely safe surgery in a skilled surgeon's hands.